Right.
Yeah, do you mind going to the next slide?
Yep. There you go.
Thank you. So this is what I would like to cover this evening. So how you can access orthodontic care, who qualifies for free or NHS orthodontic treatment, what some of the dental features are in OI specifically relating to braces, and then also what we think about as orthodontists when we're offering treatment to patients with OI. Next slide, please. Right, yeah. So this is where we were. So if a specialist such as me is in the orthodontic department of a hospital, how is it that you can come to see us to get an opinion? So your general dentist can send you in to us. If you're being seen by the community dentist, they can send you in to us. If you're being seen by a pediatric dental department, they can ask us to assess you. And similarly, if you have been sent by your dentist to see a local specialist orthodontist, so that's an orthodontist who works in a practice that will be local to your house, so relatively close to you, they will see cases that are straightforward. And if they think that either your teeth or your bite are too complex, or if they feel that the OI is a little bit complex for them to deal with, then they can send you to the hospital as well. So these four ways are the main ways that patients come into us. Next slide, please. So who qualifies for treatment on the NHS for braces? So all NHS dental care is free to anyone who's under the age of 18 years old, but that's not quite the same when it comes down to orthodontic treatment. So if you're under 18, you can get free braces, but only if you qualify based on a specific set of criteria. That criteria is the IOTN, so it stands for Index of Orthodontic Treatment Need. Part of that criteria is the little picture on the right where you can see lots of pictures of teeth. Numbers 1 is a really nice straight set of teeth that has minimal need for any brace treatment. And then as you go down the numbers, the teeth get progressively more crowded and the bite gets more complex until you get to number 10, which is a really high need for treatment. So this only makes up part of the scale that they use, but it's one of the things that they use when they're deciding whether you get braces on the NHS. So if you're a 1, 2, or 3, you're unlikely to qualify for braces. So if you wanted to have any brace treatment, it would probably be something you'd have to seek privately. When you get to the higher numbers, so sort of 4, 5, 6, even 7, you could qualify for treatment, but it's usually pretty straightforward and it would be done in a local specialist practice with an orthodontist, which is closer to where you live. Only when you get into the higher numbers, your sort of 8s, 9s, and 10s, would you be referred to a hospital setting because it's quite complicated. One of the things that we find is that um, local specialists, even if OI patients have quite a mild bite and their teeth are not that crooked, so there may be only a 4 or a 5 on that scale, normally they would see them in-house, but they still are referring them into us in the hospital because they don't have much experience dealing with OI. They don't, and they would like us to take you on for care. So that is possible. We are happy to see you within the hospital setting, but equally, we are also happy to write a treatment plan and give an opinion and then send that back to a local specialist so they can carry out your care. And the key there is that we're conscious that patients with OI often have a lot of medical appointments. Is it in your best interest to be traveling very far from home for orthodontic appointments really regularly? And is it easier for you to be seen closer to home if you can be? Then we get to the patients who are over the age of 18. On the NHS, you don't tend to get braces offered to you for free if you're over the age of 18. The one caveat to that tends to be if you need surgery to your jaws. So if you need what we call orthognathic jaw surgery, we have to wait until you've finished growing before you can have that treatment. So we have to wait until you're an adult, and then that will be included. But the vast majority of the time, you have to be under the age of 18 to get treatment. Otherwise, you're looking at going down a private route. Next slide, please, Caroline. So what age, for me as an orthodontist, what age would I like to see you at first as someone that has OI to check your teeth and your jaws? So I feel like in a lot of ways, the earlier the better, because if the age of sort of 6 to 10, you're getting your very first adult teeth are coming through. We're not really aiming to give you a lot of treatment at that age, but it's really useful for us to sort of observe, prevent where necessary, monitor how your jaws are growing, monitoring the adult teeth coming through, checking, as Fiona said, some can be missing, checking that some aren't stuck. And sometimes if we think that we can intervene at a younger age, we do. So in this sort of age 6 to 10 bracket, we sometimes provide what we call interceptive treatment. So that tends to be simplified treatment with maybe 1 or 2 key objectives that we're looking to correct, with the aim that in the longer term, any orthodontic treatment in the future will be made much easier and simpler if we act at a younger age. But if we're not doing that, then we tend to wait until all the adult teeth are through. So that's the next age bracket. If you're aged between 11 to 17, this is when all of your big teeth, your adult teeth, are coming through. And that's normally when you would have braces. So we like all the big teeth to be through. And you can then treat everything in one go, and it will take a couple of years or so. So that's when you will see the vast majority of patients have treatment. I say 11 to 17, but one of the things we know about OI patients is they're often dentally delayed. So whereas a patient might have all of their teeth through at the age of 12, an OI patient, it might be 15 or 16 or later. Then we have the adult cohort. So if you're 18 plus, orthodontic treatment is still very much possible. But within the NHS and within the hospital service, we usually only treat the patients that are going to have jaw surgery. Next slide, please, Caroline. So what does brace treatment involve? Here are some photographs of different types of braces. This is not an exhaustive list. There is an awful lot more different braces, but I think these are the key ones that it's helpful for you to see. So first, on the top left, we've got removable braces. These are braces that do small movements, limited objectives, and they come in and out, so it's easy to keep your teeth clean. Younger patients will often have these, or you may be given one of these at the start of treatment, and then it will be followed by some fixed braces afterwards. The next picture is the one on the top right, which is your fixed metal braces. So these are your train track braces. This is the mainstay of any NHS treatment. So if you're going to have braces on the NHS, you will usually be treated with fixed train track braces on the top right. The picture below that is a similar fixed treatment, but you can see the little square brackets that are stuck to the teeth. They are not made of metal, they're made of a nice white ceramic, so it's slightly more aesthetically pleasing. It's very rare to be offered this on the NHS. This is usually something that would be offered privately only. One thing to note with OI patients is often there's difficulties with teeth crumbling and breaking, and actually the metal braces are softer and kinder to your enamel and easier. So in a lot of ways, the NHS fixed braces are better for you anyway. And the last thing that I'm sure a lot of people have seen advertised or through social media, the bottom left, is aligner treatment. So this is newer, more modern treatment. Is not something you would be offered on the NHS. It's something that's usually private, and it's these little clear, they look like gum shields that pop in and out, and you change them every few weeks. Invisalign is a very well-known provider of this, but there are lots of different providers of aligners. And it's something you could have privately, but we're a little bit more limited in what we can do with this treatment compared to fixed braces, which can do a lot more. So your treatment would need to be a bit simple and neat if you wanted to have aligners. Next slide, please. So what does brace treatment involve in terms of how often do you have to come to see us? That really depends on what sort of treatment you're having and how complex it is. But on the whole, you would come to see us every 4, 6, 8 weeks, something like that. So we are aware that this is a significant time commitment for you, particularly if you have lots of other medical appointments, particularly if it means missing a whole day off school or a whole day off work in order to come all the way into a dental hospital, which is why we are keen to help treatment be provided more locally, because it will be more convenient for you. The overall treatment time can vary considerably. So if it's very simple treatment, it can take 6 months. But if it's quite complex treatment, it can take upwards of 3+ years, especially if you're having an operation on your jaw as well. So it's very difficult to give you a ballpark figure of how long brace treatment takes. At the end of brace treatment, you're always provided with retainers. So these, again, little clear ones on the bottom left that are removable. You can see the teeth on the left, it hardly looks like they're in. They look really good. And we would usually ask patients to wear these at night time. Patients typically wear them for a couple of nights a week. And we now say if you want to keep your teeth straight, that you need to wear these lifelong, because we know that teeth remember where they started and they want to go back to being crooked. And we also know that teeth like to move throughout life. And the other thing that you may be offered is a fixed retainer, which is the bottom left, bottom right pictures. And that is just essentially a little metal wire that is glued to the back of the teeth. So when you're smiling, you can't see that you've got it on, but it is something, it's almost like a belt and braces approach. If you had lots of crowding beforehand or lots of gaps beforehand, your orthodontist might recommend that you have a fixed retainer as well as a removable retainer. Next slide, please. So how does OI affect your jaws and your bite? One thing that we see quite typically in OI patients is that they come in with what we call a class 3 jaw pattern and class 3 incisors. So from the picture on the bottom left, you can see we've got 3 types of ways that we classify a jaw. So a class 1 is where the top and the bottom jaw are very similar in size to each other, and the front teeth are ever so slightly over the bottom teeth. The class 2 is where the lower jaw is smaller, so it sits further back, and the top teeth stick out more relatively. And some patients say, oh, I feel like I look like Bugs Bunny because my top teeth stick out. The opposite of that is a class 3 jaw, where the lower jaw relatively is bigger and sticks out more. And people may say, oh, my chin is quite prominent. Now, patients that have OI can present with any of those, class 1, class 2, or class 3, but we do know that more than 70% of patients present with a class 3 style of jaw pattern. Other things that we see in OI patients is crossbite. So from the middle picture, you can see the top teeth are sitting slightly behind the lower teeth, and the side teeth are sitting in front. So that's what we call as a crossbite. That can be at the front or at the sides. And another thing we often see is what we call an open bite. So the last picture on the bottom right, you can see the patient is actually biting together. Their back teeth are meeting, but nothing is meeting at the front. Nothing is overlapping at the front. There is this opening, this open bite. And you can have an open bite at the front, which is that, or you can have it at the back where you go to chew and nothing is meeting at the sides. Those are very common features that we see in OI. Next slide, please. So how does OI affect the teeth specifically? We know that about half of patients that have OI will also have dentinogenesis imperfecta. So this is where the layer underneath your enamel, your dentine, forms differently, and so the whole tooth can be a slightly different color. So they can be grayish, they can be brownish, as you can see in the picture on the bottom left. It's usually in type 3 OI, but we do get a little bit in type 1 and type 4 as well. This means that the teeth, as well as being discolored, they can wear easily and they can chip easily, which goes back to what Fiona was saying about her dad's experience of the teeth chipping. It's very, very common. Other issues that we can see, this black and white picture on the right is an X-ray, a dental X-ray of a patient that has OI. So we see missing teeth. So there will be a baby tooth present, but there won't be an adult successor there to push it out. On average, patients with OI will have 2 to 3 missing teeth in their mouth, adult teeth. We also get impacted teeth. As you look at that picture, sorry, Caroline, it's a bit tricky because it's not me sharing the screen. But as you look at that X-ray, on the left, as you look on the top, there is a little bit of impaction going on. So the back teeth are getting a little bit stuck and jumbled up. So they can't all come through, and unlikely that they will come through without a little bit of intervention from the dentist. And the last thing that we worry about as orthodontists is the actual roots of the teeth. So you can see there's a big difference on this X-ray in the lengths of some of the roots. So some of them have got really nice, long, chunky roots. And if we're moving them around with braces, we don't have any concerns about them. But some of them have got either very short or very narrow, spindly roots. And we worry that if we push them through the bone, we may end up reducing the size of the roots further and compromising that tooth. So you can end up losing the teeth earlier than you would. Next slide, please. So just to talk further about what we have concern about as orthodontists when we're treating patients with OI. So the first thing is bonding. So how can we stick a fixed brace to your teeth? The tooth and the enamel quality may mean that if we stick braces to the teeth, it either doesn't stick very well and they keep falling off, and we don't progress with treatment because you keep coming in saying, oh, it's broken again and the teeth aren't moving very well. Or when we go to remove the brace, you get chipping of the teeth and they start to break down, which we also don't want. So one of the ways that we manage this if we've got concerns is sometimes we do a little test case where we will stick a little bit of a brace to a couple of teeth further back and we see how they respond. But essentially, this is very patient specific and we often have to do trial and error to see whether it works well or not. The next thing, as I mentioned, that we have concern about is the roots. So if you're lucky and you've got really nice, long, strong roots, then we don't have great concerns about you having orthodontic treatment. But if the roots are quite short or if they're quite narrow, it's possible that the forces of the brace pushing them through the jawbone means that they might break down further, and then you could end up losing teeth, which we don't want. So we always take lots of x-rays, we look at all of your teeth before treatment, and we decide whether or not this is a risk. And the last thing that we consider is bisphosphonates. So I know a lot of OI patients have IV bisphosphonates, and we know that this affects the jaw bones and the teeth. Next slide, please. So I think talking about bisphosphonates and orthodontics is quite important because lots of patients that have other medical conditions and they're adults that take bisphosphonates, it's become a bit of a thing within the dental world that we're a bit wary of performing any treatment, particularly taking teeth out, because we worry about them getting non-healing or slow healing. So the original concerns about patients that are taking bisphosphonates is that when we try and move the teeth with a brace, the teeth will move really slowly and treatment will take a really, really long time. Or the teeth just won't move at all. They will refuse to move despite our best efforts. So that was a big concern. And the next thing, as I spoke about earlier, is we're worried about damaging the roots of your teeth, which long term would compromise their health and mean that your teeth might get wobbly and fall out sooner than we would like, which we don't want, obviously. And the last thing is a lot of patients that come to us are crowded. So they've got lots of teeth in relatively small jaws. And a very common orthodontic treatment method is to take teeth out to get some space and then put braces on to straighten everything up. And we worry about taking teeth out in patients that are taking bisphosphonates because we worry that the sockets of the teeth where they've come out, that they won't heal or they'll be very slow to heal. Or you will get what we call MRONJ, which is medication-related osteonecrosis of the jaw, which is where that area just doesn't heal. So these are one of the reasons why lots of local orthodontists will be very reluctant to treat you and why they will send you to a dental hospital to be treated. And this is one of the reasons why there's not been a lot of evidence out there, one way or another, whether it was safe to treat you. But we are getting more evidence now. There are some great Scottish guidelines from 2017. The little booklet is in purple on the bottom right, which suggests that any children, so anyone under the age of 18 that is having IV bisphosphonate therapy, is at a really low risk of non-healing or slow healing sockets. So essentially, it is safe to take teeth out in these patients. And we see a lot of OI patients, relatively a lot of OI patients in my department, and we have done orthodontic treatment on them, and we haven't seen any incidences of teeth being slow to move or not moving, any surgical complications or any issues at all. So I would just say now that more evidence is coming out there, it is a lot more positive, and there is a silver lining that orthodontics is possible and that as a population, OI is lower risk than we originally thought. Next slide, please. So just key points to take away. You usually can have braces, depending on what the roots of your teeth are like and depending on how easy it is to stick a brace to your teeth. We may sort of simplify the treatment plan and focus on making it shorter and easier so we don't get a perfect bite, but we can still get a really nice result, focusing on the long-term health of your teeth. but you definitely still can have braces in the vast majority of cases. We're also keen to say that treatment is possible locally, so closer to your home. You don't necessarily have to come into a dental hospital for your treatment just because of the OI. If your teeth and your bite are very complex, then by all means you can have treatment in the hospital. But particularly if you're under the age of 18, there's nothing really to suggest that you're higher risk than the average patient. And lastly, bisphosphonates do not appear to negatively impact your orthodontic treatment in the way that we were previously concerned that it might. So all good news, essentially. Next slide, please. Thank you very much for having me. Any questions I will happily answer.